Assalamu alaikum and hi everyone. My name is Nick Mohammad Farhan bin Nick Abdullah. I am a medical imaging student from UITM, Punchak Alam. Today I would like to share about my topic, which is radiographic image evaluation for AP foot X-ray. I will go into details for each part, and I hope all of you will enjoy my video and get more understanding about this topic. First, we need to know what is foot X-ray. A foot X-ray, also known as a foot radiograph, is a medical imaging procedure that uses X-rays to create images of the bones and soft tissues within the foot. These images help healthcare providers diagnose various conditions affecting the foot and ankle, such as fractures, dislocations, arthritis, and other abnormalities. Routine projection for foot X-ray are ap and lateral.
Okay, for this
Here is a sample video on how to do AP foot X-ray.
What I'm going to have my patient do is bend their knee up and step down right into the middle of my IR. I'm going to use a 40-inch SID. I do not use detent. And I'm going to angle my tube 10 degrees for the AP. For this one, you want to center at the base of the third metatarsal. So I'm going to move just a little bit here. Make sure that you have light off the toes and through the heel. Make sure that there's no rotation in the leg, and your marker's on the lateral side. I'm going to take my angle off for my oblique. I'm going to have my patient roll in about.
Now I will explain about radiographic image with labels of AP foot X-ray. As a radiographer, we need to know the anatomy of foot X-ray. By knowing the anatomy, we can decide whether our radiographs are good or not. First, from the most distal part of foot, we have phalanges. Each toe from second to fifth has 3 phalanges, which is proximal, middle, and distal, except for first toe, which contain only 2 phalanges, which are proximal and distal. Each phalange is connected by interphalangeal joints. Proximal to the phalanges, we have metatarsals that connected with phalanges by metatarsophalangeal joint. Each metatarsal contains 3 parts, which are head, the most distal, shaft, mid, and base, the most proximal. Then, we have tarsal bones. Tarsal bones are a group of 7 short angular bones that form the rear part of the foot, the tarsus, and are crucial for weight-bearing and foot movement. Tarsals are connected with metatarsals by tarso-metatarsal joint. First tarsal bone is cuneiform. There are 3 cuneiform, which are medial cuneiform, intermediate cuneiform, and lateral cuneiform. Medial intermediate cuneiform joint is usually seen in radiograph of AP foot. On the lateral part, we have cuboid. Next, proximal to cuneiform, we have navicular, which is connected with cuneiform by navicular cuneiform joint. Lastly, we have talus and calcaneus at the most proximal part of foot. Next, I will explain about image criteria for AP foot X-ray. There are 3 components indicating good positioning of AP foot X-ray, which are rotation, parallelity, and tilting. Let me go into more details about this. The first one is rotation. The first criteria of rotation is the distance between second through fifth metatarsals is equal. Next, the joint space of medial and intermediate cuneiforms is open. Bases of first and second metatarsals are separated. Bases of second to fifth metatarsals are overlapped. About 0.75 inch of the calcaneus is demonstrated without talar superimposition. The next component is parallelity. To prove the radiograph is parallel with the IR, we need to make sure long axis of foot is aligned and parallel to long axis of portion of IR. The last component is about tilting. To prove this radiograph has no tilting, we need to make sure there is no foreshortening of the metatarsals and phalanges. Next is the tarsometatarsal joint spaces are open. Now we will see the examples of incorrect positioning of a foot. On the left side, we can see the image of a P-left foot X-ray. This image is incorrect and cannot be accepted because first, there are rotations on this radiograph. The first evidence of rotation is the distance between second through fifth metatarsals is not equal. Then the space of medial and intermediate cuneiforms is closed. Bases of first and second metatarsals are separated, and bases of second to fifth metatarsals are overlapped. Lastly, less than 0.75 inch of the calcaneus is demonstrated without talar superimposition. The next fault is about parallelity. Based on this image, we can see the long axis of foot is not aligned to long axis of portion of IR and slightly tilted to the left. The last fault is there is a tilting on this radiograph. There are slightly foreshortening of the metatarsals and phalanges. The tarsometatarsal joint spaces are closed. For conclusion, this radiograph cannot be accepted. To improve this radiograph, first we need to rotate the foot medially until the pressure over the entire plantar surface is equal. Then align the lower leg, ankle, and foot. Direct the central ray 10 to 15 degree proximally or perpendicular with the dorsal surface. Okay, now, I will explain about the criteria for adequate exposure factors for a P-foot X-ray. There are two parameters that control the X-ray beam and influence image quality and patient dose, which is KVP and MAS. These parameters control the contrast and density for radiograph. The first factor is contrast. Contrast is affected by KVP. To ensure that the exposure is adequate, the bony cortical outline of thin structure, which is distal phalanges, and bony cortical outline for thick structure, which is navicular or cuboid, must be seen on the radiograph. The next factor is density that is affected by MAS. Bony trabecular pattern for thin structure, which is distal phalanges, and bony trabecular pattern for thick structure, which is navicular or cuboid, must be seen clearly on this radiograph, ensuring that the exposure is adequate. Here is an example of incorrect exposure factors for AP foot X-ray. Based on this radiograph, we can see the image is overexposed. The contrast is inadequate because the bony cortical outline of thin structure, which is distal phalanges, cannot be seen clearly on the radiograph, while the bony cortical outline for thick structure, which is navicular or cuboid, can be seen on the radiograph. Next, the density is also inadequate. This can be proved by the missing in details of bony trabecular pattern for thin structure, which is distal phalanges, even though bony trabecular pattern for thick structure, which is navicular or cuboid, appear on this radiograph. Since this radiograph is overexposed, the radiographer need to decrease the opacity by 2 times CAMASA, which means decreasing the MAS by half from initial exposure and maintaining the original KVP. Now we move to the next example of incorrect exposure factor. Based on the radiograph on the left, we can see that the radiograph is underpenetrated. This is because the contrast and density for this radiograph is low. The bony cortical outline for thin structure, which is distal phalanges, can be seen, but for thick structure, which is navicular or cuboid, the bony cortical outline cannot be seen on the radiograph. Next to bony trabecular pattern for thin structure, which is distal phalanges, appear on the radiograph, while for thick structure, which is navicular or cuboid, the bony trabecular pattern cannot be seen on the radiograph. To improve this radiograph, the radiographer should increase the KVP to 15%, which will increase the opacity by 2 times. Okay, now we move to the next part, which is Paceman method for image evaluation. The Paceman method is a mnemonic used in radiology to assess the technical quality of radiographic images. It helps radiologists and other professionals evaluate whether an image meets the necessary standards for diagnosis. The Paceman acronym stands for P, projection and positioning. What is the projection for the radiograph? Is the patient positioned correctly for the specific radiographic exam? A, alignment. Is the alignment for this radiograph proper? C, collimation. Is the X-ray beam properly collimated, limited to the area of interest, minimizing unnecessary radiation exposure? Any sign of radiation protection? E, exposure. Is the exposure level, contrast, density of the image appropriate? M, marker. Is the necessary patient anatomical marker present and correct? A, aesthetics. Does the image look visually appealing? Has any artifact? And what size of the cassette used? N, name. Is the patient's name and other relevant details clearly identified on the image? Now we start with projection. Based on the radiograph on the right, this is a radiograph of AP left foot X-ray. This is foot X-ray because the entire foot is included on this radiograph, starting from phalanges, metatarsals, navicular, cuneiforms, and cuboid. Proximal calcaneus, talar neck, and surrounding foot tissue are included. This is AP foot because the joint space between medial and intermediate cuneiforms is open. Now we talk about the positioning. The positioning for this radiograph is correct. I say so because the joint space between medial and intermediate cuneiforms is open. Next, the tarsometatarsals joint are open. About 2 centimeters of calcaneus is visualized, without superimposed with talar. Bases of 2nd to 5th metatarsals are superimposed. The next point is about the alignment. There are 3 components of alignment. The first one is the alignment between X-ray tube and cassette. The second one is the alignment between patient and cassette. And the last one is the alignment between X-ray tube and patient. First, the alignment between X-ray tube and cassette is incorrect because there is no evidence of 4 sides of collimation. Next, the alignment between patient and cassette is correct because the distance between the edges of the cassette, which is shown by yellow line, to the central structure is aligned, which is at the base of the 3rd metatarsal. The alignment between X-ray tube and patient cannot be determined because there are no 4 sides of collimation. The centering point for this image cannot be seen because there is no collimation border for this image. Last, the standard centering point is at the base of the 3rd metatarsal. Now, I will explain about the collimation for this radiograph. First, at the superior border, the distal phalanges should be included on the radiograph. At the inferior border, at least 2 centimeters of calcaneus is visible on radiograph. For the medial and lateral borders, soft tissue margins of 1st and 5th metatarsals are included on this radiograph. There is no evidence of radiation protection given on this radiograph. Next part is exposure. The KVP used is adequate for penetration and radiographic contrast. This is because the bony cortical outline of the thin structure, which is distal phalanges, and thick structure, which is navicular or cuboid, can be seen. The MAS used is adequate for detail and density. This is because the bony trabecular pattern of the thin structure, distal phalanges, and thick structure, navicular cuboid, can be seen. The KVP and MAS remain the same, and no changes are needed. Next, for marker, based on this radiograph, we can see that anatomical marker can be seen, located at left superior, and do no superimpose with region of interest. The next component is aesthetic. The film size used is 10 x 12 inch, which is sufficient to demonstrate all the structure of interest for a P-foot X-ray. There is no evidence of artifacts seen on this radiograph. The last component of PACEMAN is name. The patient's name and ID, date of examination, place of examination are not visualized on the radiograph. In conclusion, the radiograph of a P-left foot X-ray is unacceptable because there is no patient's identification, which is a very crucial component for radiograph. These are the references that I used in producing this video. Most of my references are from textbooks that are usually used in medical imaging field. Bontrager and Lampignano, 2014. According to Bontrager and Lampignano, accurate radiographic positioning is crucial in producing high-quality diagnostic images. McQuillan-Martinson, 2020. McQuillan-Martinson emphasizes that thorough image analysis helps radiographers detect positioning errors and improve diagnostic outcomes. Nadjri, 2011. Nadjri explains that using a systematic approach in evaluating radiographic images ensures consistency and accuracy in clinical practice. That's all for my video. I hope all of you get something from my video and have clear understanding on radiographic image evaluation of a P-foot X-ray.